Good afternoon, ladies and gentlemen, and thank you for standing by. Welcome to the CHSRF On Call. At this time, all participants are in listen-only mode. Following the presentation, we will conduct a question-and-answer session, and instructions will be provided at that time. If anyone has any difficulties hearing the conference, please press star followed by 0 for operator assistance at any time. I would like to remind everyone that this conference call is being recorded today, Wednesday, September 21st, 2011 at 12 p.m. Eastern Time. I will now turn the conference over to Mr. Stephen Samus, Vice President of Programs. Please go ahead, sir.
Thank you, and welcome everyone to CHSRF On Call. This is an interactive series by the Canadian Health Services Research Foundation, which brings together policymakers, healthcare executives, researchers, the public, and you to be part of a dialogue about ways to improve healthcare for Canadians. As you heard, I'm Stephen Samus. I'm Vice President of Programs here at CHSRF, and it's my pleasure to welcome you to today's call, where we're talking about patients as partners in our healthcare system. Including patients in discussing issues and sharing in decision-making can lead to more effective delivery of healthcare services. Research shows that patient-centered care, with its focus on patient preference and experience, is a key component of quality. Today, CHSRF On Call examines the role that citizens play as patients, as decision-makers and caregivers, and how these roles are changing dramatically as part of healthcare reform that's happening across the country. It is a pleasure for me to introduce for you our speakers today. Joining us today are Matthew Mendlesohn, Director at the Mowat Center for Policy Innovation, and Will Falk, Executive Fellow in Residence, Health Policy and the Public Sector Transformation at the Mowat Center for Policy Innovation in Toronto, and Kelly McQuillen, Director of Patients as Partners, Primary Health Care with the BC Ministry of Health Services in Victoria. Also, we're pleased to have had more than 200 organizations registered today for our call, with representation from one coast to the other across the country. Today's call begins with a brief presentation from each of our three speakers, and then we're going to open the lines for a question and answer period. And I'll be taking the questions from you, our audience, at that time, and I'll also be providing instructions for how you can pose those questions both online and over the phone. So it's now my pleasure to hand the floor over to Matthew Mendlesohn.
Hi, everyone. Thanks for joining us. You can eat your lunch, stop checking your email. Will and I are going to be sharing this presentation. I'm going to be mostly talking about the past and what has been going on in this area. I'm also going to be situating my comments in a broader context of citizen engagement and public service transformation generally. So the trends we're going to be talking about are not taking place just in the healthcare area, which will talk about more explicitly, but are taking place across governments and public sector institutions as they try and transform how they go about doing their business. One of the main messages that I'd like to leave you with, and will pick up on this theme, is that the last 10 years have featured the elaborate construction of building an infrastructure for accountability and transparency, and have created the platform for citizen engagement, patient engagement, and healthcare practitioners to be more individual and creative and flexible in how they manage care. And so if the last decade was about building that infrastructure and supporting accountability and transparency and information, the next decade is going to be about how patients and healthcare providers start to use that information in flexible ways, some of which may not have been predicted. So a lot of this begins with the Romano Commission that popularized the notion that healthcare is an important symbol of Canadian identity, and our publicly funded healthcare is important to us as Canadians. It began to measure public opinion on healthcare and started to report it on a regular basis, and created the culture whereby accountability, transparency, information sharing, providing citizens with information about their healthcare system became very important. Obviously that had been going on before, but the Romano Commission popularized that notion. the First Minister's meeting on healthcare created a national system of provincial reporting, or at least created the platform by which we could begin that provincial reporting. Transparency for surgical wait times became the norm. Patients and families began to check websites when booking surgery. Local press coverage and national press coverage began to be important about measuring hospitals at local and regional levels. So all of this was prologue, and people on this call would certainly be aware of most of this kind of information. Ontario just put up a slide there that talks about waittimes.net and being able to track wait times. This is not going on just in Alberta, but it's going on nationally as well. The thing to note about this is that it created a variety of different organizations and institutions that report on quality. I mean, some of the most important ones, as people here know, the Canadian Patient Safety Institute, CHI, the Provincial Quality Councils, and a variety of others, which have been creating the platform for citizens to be more informed decision makers in making choices about their own health care, and provides a kind of accountability and transparency as individual healthcare organizations feel public pressure to do well on a variety of measures. People would certainly be aware that one of the Premier of Ontario's prime messages in the current provincial election campaign is references to where wait times were previously and where they are now. So clearly this fits in a broader political macro context of accountability and trying to be seen to do well on various performance measures. As part of access to care, the Ontario government mandates public reporting on a variety of different issues, and healthcare executives take these seriously and take performance on these measures seriously. One of the other messages that I want to, and this is just a snapshot of some of the indicators that are being used on excellence, access, effectiveness, safety. One of the other things that we want to talk about, though, is that while governments, bureaucracies, healthcare policy elite, policy, the healthcare policy community and leadership of the healthcare policy community have been building a variety of these organizations, there are, of course, a variety of other organizations that are emerging, that are driven by individuals and citizens or individual healthcare providers, that are facilitated by technology. And that is also one of the main messages of my part of the talk, which is we've been building the infrastructure for information sharing, transparency, accountability, while at the same time the technology has been evolving very, very rapidly that facilitates a variety of other forms of citizen engagement and patient engagement. And these are beyond the control of government, but they provide citizens, patients, but also healthcare practitioners a variety of tools, and they are evolving in ways that government wouldn't necessarily predict. And as we segue into Will's part of this talk, that is one of the key issues that I would like to leave you with, that if the past decade has been about accountability, measurement, transparency, public reporting, building that platform of measures and indicators that can be reported on, increasingly we are moving into a period where individual patients and healthcare practitioners will now deploy this information both in the public realm but also through a variety of private or nonprofit sector organizations in a whole series of ways. So from my background in citizen engagement and public engagement, we're moving from a period of accountability and transparency to adding a period of control for individuals, tailoring of services for individuals, flexibility for individuals, and that's patients and healthcare providers, and moving away from a period of bureaucratically government-driven and controlled period. Clearly, the importance of government bureaucracies and the healthcare professionals and the healthcare policy community to define a lot of the terms of debate is still going to be important. But once that platform is created, we now move into a period where the definitions of things like access and quality are not simply defined through consensus amongst the policy community in the health policy community and governments and in research institutions, but will increasingly be defined individually on a day-to-day basis by patients and healthcare providers. And so with that, I think I'll turn it over to Will.
Thanks, Matthew, and hello, everyone. I'm going to talk a little bit about the future and some of the current fast-moving trends that are going on. We have in healthcare seen an explosion of virtualization at the institutional and patient levels both. And for patients as partners, this has begun to create new ways of interacting with institutions. Ontario is a real leader in this world with the Ontario Telemedicine Network, the UHNGE telepathology, now ubiquitous tele-DI, and private companies like PharmaTrust, which is virtualizing pharmacy. Virtualization is, as I said, happening globally across many industries. Healthcare, if anything, is a bit late to it. Virtualization will define as being the separation in time and space of patients from the treating provider. And virtualization allows many process and quality and access improvements to take place. At the same time, we're seeing social networks being used, often patient-motivated, sometimes not health-specific networks, sometimes health-specific networks. Many interesting anecdotes about how Facebook is being used, how people are sharing disease stories and treatment stories in networks like Patients Like Me, which is a data-driven social networking site that allows patients with common diagnoses to register and share information. A great recent report that I presume many on the call are familiar with has come out of the Change Foundation and the Health Innovation Cell here at the University of Toronto with Neil Seaman's work. I'm sorry, I've advanced too far here. That work has allowed or does a good job of summarizing some of the many trends in the area. The other piece that's coming now quite quickly is the virtualization of the home. There are a number of private companies that have major initiatives in this area, often at the moment outside of the public healthcare system, that are promising a lot of benefits and some interesting connectivity in a health-specific space. But also in the non-health specific space, we have low-cost alternatives that are emerging that are quite interesting. I've got Xbox Connect pictured here, which is a video game without a game controller in which 24 body joints are tracked, and it allows for a number of interesting off-label health usage, which is becoming quite common. The overall piece on Connect is that it does allow the tracking of the different parts of the body quite well, and use of an avatar in clinical settings is also now possible. Going forward, the virtual visit is beginning to happen, often in an unstructured way at the moment. 75% of U.S. doctors now own an Apple device. I don't know the number in Canada, but the anecdotal evidence is quite high. Can I ask you guys to take over and put me on to slide 5, please, because I'm having trouble. Thank you. The next generation of devices is allowing both physician-to-physician contact or clinician-to-clinician contact, but also clinician-to-patient contact. We've seen the demise of the pager in many hospitals. Many of these devices still outside of our formal e-health framework and formal InfoWay framework, but nonetheless being adopted very quickly on the ground, particularly by younger providers, and being used in some interesting ways to diagnose and treat patients as partners in their care processes. Advance, please. Kaiser, a good article in Health Affairs 2009 that showed a 26% reduction in physical visits by the introduction of the virtual visit in the first 18 months. It's reported in Health Affairs 2009 along with their EMR. One of the big goals that we're going to have in public policy in the next couple of years is likely to be getting the physical out of the fee schedule. The physical is so embedded in the fee schedule that it is at the moment blocking innovation. And so on a province-by-province basis, on a schedule-by-schedule basis for hospitals, for doctors, we're going to need to get the assumption of physicality out so that we can see these benefits and see these pieces moving forward. But policymakers should be intrigued and attracted by numbers like a 26% reduction in physical visits and the attendant ability to open up capacity hugely by doing those. Now, if you look at the existing regs, as I'm sure people on the call know, they effectively prohibit the use of virtual visits in many cases by having minimum times and other arbitrary rules which make no sense except in a current environment. So moving forward, getting rid of the physical and moving to a virtual visit structure will restructure how patients can interact. Next slide, please. In back of all of this is a data liquidity piece that I've got the Microsoft Health Vault being shown here. In Canada, that's being branded out by TELUS and will be part of the phone company, the same way that the home health piece will be provided by telephone companies in the longer run and be provided that way. Next slide, please. Final example before summing up. Point systems for ER wait times are now up. The first one's in Ottawa in Canada that I'm aware of, but there are about a dozen across the U.S. This example is from Auctioner down in Baton Rouge. They're feeding 311 system real time. Last slide, please. Or next slide, please. While these solutions, another click please, will emerge as point solutions, patients as partners and consumers will quickly bundle and integrate them so that the virtual pharmacist from the virtual pharmacist and the virtual nurse and the virtual doctor will become integrated either through a family health team in Ontario or perhaps as point providers connecting across. The Connected Home for Chronic Care will come up. Quality reporting and access reporting will be in the background, as will the ER pieces. Telepathology, telediagnostics, teledi will all bundle as well, and we will pull together a set of integrated solutions as we mix and match across this virtual healthcare supply chain that will have the patient as the center and the partner in organizing the care. With that, I'd like to close and pass to Kelly.
Thanks. So my opportunity here today is to share with you sort of what's actively happening on the ground in BC in primary health care. I'd like to thank CHSRF and also to tell people that this is a collaboration of many partners, the BC Medical Association, Ministry of Health, our health authorities, our non-governmental organizations, universities, and most importantly, patients, families, and caregivers. So I'm going to pepper my presentation with some of the examples that are underway in BC around patients as partners in integrated primary and community care. We came together in 2008 to look at a definition bringing together patients, families, caregivers, providers, and administrators to talk about what we mean by patients as partners. This definition is where we landed after lots of consultation to talk about patients, families, caregivers, and their partners doing four things: participating in their own health care, in the decision-making about that care, at the level they choose, and also to have an opportunity to participate in quality improvement and healthcare redesign in ongoing and sustainable ways. And we really looked at doing this through the principles of patients and family-centered care, looking at dignity and respect, information sharing, collaboration and partnership as the platform by which we would approach our work in the future. We also looked at using the IHI model for improvement and the triple aim approach. And we really aim to leverage the patient voice for improvement through looking at triple aim, our three-legged stool of really not just focusing on cost, continuing to focus on population health outcomes, but to really bring to the forefront the experience of the patient and the provider into the story and into the data, the stories with the tears wiped off, the data that we'd be using to improve our healthcare system. We moved from this work to 3 improvement charters, and then from our 3 improvement charters provincially, we moved to developing with our many partners a patient and public engagement framework, knowing that patient and public engagement would be key to the triple aim, key to innovation, and key to transformation. And it really would be central for us to achieve success in our system. We definitely worked to create a common language by having a framework that we all used. We used the International Association for Public Participation, their principles and their spectrum of engagement, but dialogued that in a BC context, and created a training program for our health authority and ministry staff around the principles of engagement and the spectrum of engagement, and also created a toolkit which we're still working on to bring online and to do a train the trainer to actually engage our providers and our administrators to be ready to engage with the public. And similarly, through our CHSRF project, which I'll talk about later, we're also training patients on this framework and how to become engaged in the system. So I'm hoping this won't go too far here. So we've also been working around a stepped approach for engaging patients and public in healthcare. And this stepped approach has really looked at engaging people in their own health issues from self-management, and then moving them forward from their own health issues to their community, their regional health authority, the province, and then policy and decision-making at the provincial table. The stepped approach for care and self-management tells us that we need to meet the basic needs as a foundation to support engagement. Looking at Maslow's hierarchy of needs, we need the foundations of health literacy and cultural humility to actually move us forward if we want proactive and active patients and engagement in the system, but also in their care and quality improvement. So really using this model that Connie Davis and others in BC and nationally are working on, we've been working through this stepped approach to saying that there is a way that patients and public become engaged in the system. Not everybody is ready to jump into a policy table and to be actively involved in system redesign. So through this lens, we've been really developing self-management services and self-management supports. We've done some mapping in BC to look at what services are out there. We've looked at the fidelity standards. We've looked at provincially where we can fund these programs. We've designed an evaluation framework and looked at evaluation tools. And we have a number of self-management programs that we are delivering across BC. Our aim is to ensure access, that the program is offered at least once a year within a 50-kilometer radius of all participants in BC, all patients in BC. And we achieved that goal to 75% in 2001. We continue to, based on patient input and provider input, to expand our options. We hear that we need to have different options, including online rather than just face-to-face, and looking at technology to support increased access for these services. We also, in 2008, heard from patients that we really needed to develop a mechanism for the patients and the public to be engaged in quality improvement and system redesign. And the Patient Voices Network is a Patients as Partners initiative that is led by Impact BC in collaboration with the Ministry of Health. And it's designed by patients for patients in partnership with many of our providers, including our health authorities, the BC Medical Association, and NGOs. And it really is a mechanism by which we can recruit, train, and support patients and their families to participate in changes at the individual level, the community level, and the system level. The network itself has two components to it. It has a registry side and a database and a website where patients come on. They are able to do e-learning. They can receive information, news, polls, surveys. They can have offline engagement. And an activated network where we actually provide orientation, training, and coaching for patients to be involved as peer-to-peer coaches around healthy living issues, to shape the system, to become involved in quality improvement teams and at policy tables, and to become activated in their community. And our philosophy here is that we work in collaboration with partners. Change takes time, and not all change is an improvement, so we use the model for improvement. There's many voices and there's many opportunities. We've done over 500 placements of patients, families, or caregivers on initiatives in BC, and we ask patients to practice self-care in terms of the level that they choose to be engaged and how active they are in the engagements. Through our funding with CHSRF, we've been very fortunate to work with the Fraser Health Authority, Impact BC, the UBC Faculty of Medicine in their eHealth Strategy Office, ICON, and with patients. And we've been developing an initiative that would improve and prepare patients to authentically participate in health system redesign. We are developing orientation and training with patients and providers together around Health System 101, how does the system work, how to become engaged, and talking about the principles of engagement and the spectrum of engagement and the skills for engagement, and communication and listening. And these sessions are being offered face-to-face, and we are also developing them with the Intercultural Online Network in Punjabi and Chinese, as well as English, and delivering them online. I've mentioned the UBC Faculty of Medicine and the Intercultural Online Network. It is an initiative that we have been really privileged to work with the university, helping multicultural and First Nation citizens, patients, and caregivers in chronic disease prevention and management through effective communication, knowledge exchange, and social support using modern information and community technology. And so it's central that we are working with the eHealth Strategy Office. The work that we're doing and that we're leveraging through UBC is to deliver large forums in person and online to promote partnerships between consumers, professionals, and administrators, peer-to-peer, and across generations for collaboration in health. It involves online information, live forums, and these are delivered in Punjabi and Chinese language. There's video conferencing infrastructure used and leveraged from our health authority partners across BC, and we do live webcasting, and we're able to really engage large numbers, up to 1,500 people coming out to a forum and then connecting across the province online through webcasting. Another area that we've been working in is patient journey mapping, and this is a partnership again with the health authorities and Impact BC to look at a suite of tools that we can use for patient journey mapping. It basically anchors changes and improvements in the patient journey, making a connection between what the patient knows and feels and what clinicians know and feel, and using that shared pool of knowledge and the wisdom that comes from it to create opportunities for change and quality improvement in the system, and to take those changes and transform the system for a better system. So you have a patient journey map here of how the system in Quesnel was working before the journey mapping, and then after the engagement of patients and providers together and the quality improvement opportunities, what the map looked like for patients afterwards. We're developing an online training and suite of tools, and also looking at the similarities of this are very similar to the experience-based design in the UK or value streaming from the lean process in acute care. We're doing this in community with a large number of stakeholders, as well as in looking at it application in acute systems. So finally, we also have an initiative that we've been doing with the General Practice Services Committee, which is a partnership between the Ministry and the BCMA and our health authorities. We've leveraged a suite of tools to improve care and practice redesign and to bring in the voice of community. We've been looking at opportunities to get patient experience data from the patient perspective, and we've leveraged a partnership with John Wasson and Dartmouth College to actually start looking at a suite of tools that would help us to understand the access, the continuity, the coordination, the comprehensiveness of services in primary care practices. This started as a paper-based tool. It's had about 10 years of research and improvement on it, actually about 20 years. It's been available online for 10 years and has over 180,000 U.S. users, and we are looking to bring this tool into Canada to leverage the work that's been done and to put a Canadian context to it. So we had a value test with family practices. Of the family practices that participated, 80% of them said they would recommend this to a colleague as a suite of tools once it's brought into Canada and Canadianized in content. So basically, our vision for the future is a system that actively reflects the needs and interests of the people it serves, the patients, and we believe we need to ask the patients to be our partners in care. Thank you.
Thank you very much, Matthew, Will, and Kelly, for 3 great presentations. Very, very interesting as we move forward. The opportunities for and the need for including patients in self-management and in the improvement of healthcare delivery is obvious from the presentation. So we very much appreciate that today. And we now have the opportunity to turn it over to those who are on the call today. Both those who are listening in and through the web, you can write your questions. There are 2 ways you can pose a question. You can ask it verbally. And to do that, please press *1 on your touch-tone telephone, or you can ask a question electronically. And to do that, you use the question box located on your control panel as illustrated on the slide, and type the question in. We would ask you, when asking a question, to please identify to whom the question is addressed, and if you could please try to ask 1 question at a time so that we can move on and include others in the question and answer session and the discussion. We have a question now, which is, how can we leverage lessons learned from our various provincial and local engagement initiatives to expedite public participation in health system sustainability? That isn't identified toward anyone, but Kelly, would you be able to take that one on?
Sure. I think that one of the big opportunities has been through the PEP projects of CHSRF, where there's a number of projects across Canada. We've been able to come together. It's been provided an opportunity for us to meet and to talk and share. So I think that's one way. I think another is just creating an online community. So leveraging technology again for us to share across provinces. And again, we've been doing a little bit of that with the CHSRF in posting documents in a common site. So I think that we certainly could leverage technology, as we've said patients and the public can do, to actually create an online community of sharing.
Thank you. Another question here for you, Kelly. What do we mean by cultural humility?
It's really looking at the different cultural contexts and the cultural lens in which providers approach patients and patients approach providers. So we've been doing a fair amount of work through the Provincial Health Services Organization around cultural competence training, just being aware of the context in which people live, work, and play, and the cultures that they bring with them. I think that it's a very big foundation for self-management in that Some cultures have different approaches as to who is really responsible for care and how patients and families engage in care. And we really need to understand that as providers and talk to the public to look at how they would best receive or access care. And so really understanding the cultural context in which we're working and the foundations of the people we're working with.
Thank you. This one for either Matthew or Will, perhaps Will on this one. How is the patient's confidentiality protected with this type of form and access to medical professionals and information, particularly, Will, in terms of some of the new technologies that you were profiling in your talk?
It's a great question. I think what we're seeing is that the one-size-fits-all privacy approach that we've, for good reasons, taken to this point as we've laid the foundation of the system is actually going to need to split into a multi-tiered approach. We're going to see different people take different approaches to their privacy, and that's okay. There are people who are going to choose to put details that others might be uncomfortable with up onto Facebook and to Twitter. There are going to be people who are going to make the decision that they don't want to do that. And there are going to be times and places when things are going to have to happen in different ways. The challenges for the privacy commissioners and for others who manage in this area are going to be really, really difficult. I'll give you one example, a real concrete example if I can, of where this is already happening. I made reference in my talk to the end of the pager in the hospitals across Canada. By some estimates, pager volumes are down by 70, even 90%. And of course what's happening is that residents and interns are forcing a switch to texting and to emailing. Well, for better or for worse, folks, some of those emails are not on hospital systems. Should people not be communicating? Well, how are we going to allow those communications? When do we think it's okay? How do we make that work? And where does that go? If a patient emails, I've emailed my son's pediatrician from my Hotmail account to her Rogers account. Is that okay? I think it's okay. She thinks it's okay. How do we handle that in privacy legislation? A lot of really difficult, nuanced questions that have to be worked through on this. Matthew wants to add a comment.
Yeah, I just wanted to add very briefly, I agree with Will on absolutely everything he said, and I situate it in a broader context that I started with at the beginning, which is that there are official definitions of privacy or bureaucratically driven definitions of privacy that privacy commissioners have been defending for good reason for an extended period. But not just in healthcare, but across the board, individuals may have quite different definitions and be willing, as Will said, to make different trade-offs at different times, and they are increasingly being empowered to do so. And if they choose for convenience to do a certain thing that a privacy commissioner doesn't like, I think privacy commissioners have to evolve and recognize the evolutions that are going on and the empowerment that individual patients and citizens have.
Thank you. We're going to do one more here from online, and then we're going to go to the phone. Kelly, a question for you from Sharon. How will patient voices engage citizens who are facing the cognitive challenges which arise from the effects of mental illness, including difficulty with concentration, attention, etc.? People who may or may not be able to sit through long meetings. How do you see the role of the patients as partners evolving for them and for those patients who would have challenges with that format, but who still want to engage directly in the healthcare system and also health system improvement?
That's an excellent question, and I think that the answer lies in asking the patients how we best engage with them. We work closely with the Canadian Mental Health Association, our BC division. We work closely with the service delivery providers in that area, and it really for us is the Patient Voices Network is rather new, but we do have targets to engage with with the frail elderly, to engage with cultural groups and diverse groups, to engage with youth, which are also hard to, at times, we don't see their voice, and to really reach out and ask those people how best to engage. So we started off with face-to-face training. We're moving more to online, a blend of online and face-to-face. We're moving to partner with our health authorities to do more local and community training and engagement, as we've trained in the health authorities around the IAP2 framework for engagement. But I think that essentially even the Patient Voices Network as it's currently designed, we went to patients, families, and caregivers and asked them what that mechanism looks like. So I think for those that have literacy challenges or cognitive challenges or disability challenges, we really need to ask them what mode of and what methodology should we be using to bring their voice into the picture. We haven't done all of that yet, but that definitely is on our agenda to work directly with those groups to find a way to engage them.
Thanks, Kelly. That's a truly inclusive approach. Over to the operator now so that we can take a call from the phone.
Your next question comes from Paul Gallant from Gallant HealthWorks. Please go ahead. Your next question comes from Kathy Kastner from AbilityForLife.com. Please go ahead.
Hello. What a fabulous webinar. Kelly, I'm an instant devotee. I think it's just fabulous what you are doing, and I'm going to speak quickly because I'm hosting a tweet chat at 1 o'clock, should anyone want to join, Healthcare Social Media Canada at 1 o'clock. But my question is actually for Matt, perhaps for all of you. When you started off saying the last 10 years have been building the infrastructure and accountability, what about interoperability, which Will, I think you referred to when talking about texting or emailing? I'm assuming you understand what I mean by interoperability.
Hi, it's Will. Yeah, you're right. Many of the solutions were point solutions as they first emerged. So, and in fact, I'm still a real devotee of wanting to get a much more formal way of mashing some of the different sites. So, you know, I think it's great, as Matthew talked about, you know, it's great that we have an access to care reporting system and a quality reporting system, and that you can go somewhere else and get the cost data, and you can go somewhere else and get other data. But there is no connection there is no interoperability among those. And just as you know, it would be useful it's useful in other industries to mash data. I think it would be great if we could get the mashing going that way. Picking up on an earlier question, there is a kind of a low-tech workaround that's been happening in communities across the country that's very interesting, which is the local community newspapers have really picked up these data sources. And so the ECFA data and the access to care data are regular fodder, and also some of the CHI data on cost and equity and HSMR get picked up by the local papers, you know, the Barrie Examiner, the Orangeville Banner, those kinds of papers pick them up and run the stories, and there's a real accountability there back to citizens that I think has some value. It's a low-tech workaround. We should do better. I'm fairly confident, though, that it'll come over time, and I'm comfortable that people using point solutions and really getting value out of point solutions should be allowed to do so in a kind of an unfettered marketplace. I worry sometimes that we overload our systems. I hope I answered your question.
Thank you. Well, while you're close to the phone, there's two related questions here. One was, could you describe more the Microsoft Health Vault and how that's used? And I think related to that, are there examples of where these sort of physical technologies, the technologies that are being used virtually to assess, you know, physical fitness, etc., have been successfully removed from the fee schedule? And have you thought of ways or concerns about this from physicians?
Okay, so that's two really big questions. I'll deal with them quickly. The Health Vault is installed and running at several U.S. institutions pretty well, and of course it's free to U.S. consumers. But New York Presbyterian and Mayo Clinic are the two that I would probably point out. I'm hopeful that it'll come in Canada because TELUS has picked up a license and is running with it. And TELUS has a real interest in doing that and has some smart people who are thinking about it. The idea behind things like the Health Vault has been around for about 5 years now. The idea is that you as a citizen control putting information into the vault, into the Health Vault, and then the dissemination out. It is using some standard formats in the industry that will be familiar to many on the call. The revenue model has been a problem to this point. There is a role for government in solving that revenue model. I'm hopeful that it'll be solved in Canada, but it is by no means a slam dunk. If it is solved, it'll be exciting. The second question, Stephen, what was the topic?
The second one is basically, have you seen any instances, or has there been any? To what extent has there been movement on removing the physical exam from the fee schedule? And what are any reactions you've had from providers on that?
So clearly we've had the big workarounds on Ontario Telemedicine, the North Network, other telemedicine programs that have provided excellent workarounds to allow particularly specialist-to-specialist consultations and others. And those have been great and very successful. And we're a first mover in Canada, and particularly in Ontario on this, because of the leadership by OTN and others on it. What I'm suggesting, and the reason I use the language getting the physical out of the fee schedule, is I'm trying to speak to the bureaucrats who will actually have carriage of this. We need a systematic way of looking at where we've got a problem. Conceptually, it's fairly easy, right? We can do the same thing whether it's done physically or not. So, for example, we can renew a maintenance prescription without seeing a patient. If we're getting, for the sake of argument, $17 for that today, and the physician's willing to do it virtually for half that amount, $8.50, then we've got a win for everyone. The patient wins because they spend less time in the waiting room. The physician wins because they're able to create a new process, often leverage, that will allow them to do that quickly and easily. The system wins because we're getting the same output for half the cost. The issue, of course, is that you have to get agreement amongst the parties to do that, and that is, as we all understand, non-trivial. I think it'll happen. The gains are, on the order of a 1/4 reduction in visits because of the high percentage of visits that do not actually require physical contact. I am not arguing that there are not many visits that do require physical contact. Of course there are, but there are also many visits that don't, and we should get on with the modernization of the healthcare system on that line. I do think, I'm just going to hit this one hard if I can, Stephen. I do think that it is a little odd that we've spent something north of $3 billion trying to get people to adopt 21st century technologies, and in most provinces we still don't let physicians use the 19th century telephone.
An interesting point, exactly. Thank you for that. Certainly work that we can be doing collectively with other organizations and CHSRF in bringing people together to discuss how we actually move forward on some of these issues and ensure that we're making the most of the technologies that are becoming available. This one, we have a question from Paul. We lost him on the phone earlier, but here's one here in writing, and probably for Kelly. How can we leverage lessons learned from our various provincial and local engagement initiatives to expedite public participation in health system sustainability?
Great question, Paul. And Paul has also had the opportunity to work with us on our CHSRF work. I think really it is the stories. It's the patient voice that will actually leverage the biggest change in the system. And so bringing the positive experiences that we're having across the province, bringing them to the media front, and that's not an easy challenge, but I think that telling those stories about how partnerships and how improvement opportunities where patients have lent their voice to not only the problems but the solutions and the decisions, and documenting the successes are probably our biggest success in sharing across the provinces where it works to actually have patients in the mix. So, you know, certainly we don't do enough of that. We do our improvement initiatives, we take it within the system and we learn, but we don't communicate out to the public about the types of positive changes that are being made in partnership with patients and the public when they're being made. So I think it's really communicating out, using as many sources as we can, going, you know, not just within government, but outside to our partners to have them help celebrate our successes through their networks.
Thanks, Kelly. That's great. There are so many terrific questions on the line today, both here in writing and also on the phone. Operator, can we go back and take a question from a caller, please?
You sure can. Your next question comes from Paul Gallant from Gallant Healthworks. Please go ahead.
Hello again. I reconnected. Thank you for your answer, Kelly. My next question, and I feel I'll just ask the question. What's the time frame for rolling out any other initiatives that you may be aware of across Canada, not simply just in British Columbia or in Ontario, for example? Are there other initiatives kind of in the works that you're able to share? And this is for any speaker.
I don't know if CHSRF might want to respond to that in terms of all of the PEP projects and the work coming out of the first round.
Sure, I could respond to that. We at CHSRF we have thanks, Kelly. We've actually supported now a total of 17 teams from across the country. 17 examples of institutions, organizations, ministries, health regions who are working to facilitate patient engagement as a lever for healthcare improvement and transformation across the country. And we're bringing those teams together in real time so that they're learning from each other, sharing what they've learned, ensuring that lessons learned, things that work well and things that don't work as well are shared amongst the groups. And then we will be increasingly doing things like this and policy briefs and other dialogues and trying to get the information out from the lessons learned from these projects over time, and then hopefully taking our patient engagement work to another level and continuing to build on the successes that we're starting to see through the kinds of projects that we have supported, including the one that Kelly is organizing in BC. Kelly, there's a related question here in writing for you, and it's related to, a little bit related to what I said, but more specific to yours, and that is the Patient Voices Network open to non-BC residents? In other words, how can patient groups access the online training, or can they access the online training in British Columbia?
So we've been in operation just over a year now, and certainly the network is open. You just go to patientvoices.ca, and anybody can leverage the information and see the information that's there and learn about and join our webinars. We've had patients and providers from across BC joining our learning webinars, so we do have online webinars. In terms of our engagement opportunities with our partners, we often post those engagement opportunities through the Activated Network and train people through the Activated Network to be involved in the BC healthcare system and the system changes that are happening in their health authority or in their community. And so a lot of the training is sort of geared around what's going on in BC. So that Activated Network side has, till now, it has really been focusing on primary health care, home and community care, mental health and substance use, our partners in those areas, and doing the training on that end. I think that the aim for us is to really find out from patients where else they need to engage, and certainly our acute care sector has also leveraged patient voices in BC. So the website is open to everybody. Right now the training is just taking a shift from face-to-face to moving into an online and a virtual, and more localized into health authorities with our health authority partners. So I would encourage people to go see what has been created in the last sort of just over 12 months. And we're using a model for improvement. So we are always improving, and so we're welcoming others to come and learn and share what they think could be improved with our system.
Thank you. I'm going to go online now, and this is probably for Matthew or Will. Can you comment on privacy legislation and the challenge of using technology to communicate directly with patients? This comes from Carol, who says her organization does not permit them to communicate with patients via email.
Wow. That's a tough restriction to be operating under. I mean, I'm sure that many folks on the call are listening to that and wondering how they would deal with their day-to-day life if they were unable to use an email. I am not a privacy expert, and I don't want to get put in a position of using a privacy expert or as a privacy expert. I certainly do think that it is the case that private communications can be done by email and certainly be done with the consent of the recipient, whether individual organizations are choosing to interpret things that way or not. Modernizing, I guess I should just say, I think it's a non-sustainable position in 2011 for any organization to say that they're not going to use email. Matthew wants to comment.
I likewise am not a privacy expert, but I do consider myself a privacy victim in the sense of when I was in government, we had to navigate the privacy laws in ways that, for people who were trying to do their day-to-day work effectively, were sometimes obscure and complex and made our jobs more challenging, and obviously one wants to protect privacy. But I do think that we are in a period where a variety of important public concepts like privacy that have been defined over the last 40 years are going through periods of redefinition, and we are entering into a period where the traditional stewards of all of these things, whether those are health policy community in some areas or privacy experts in other areas, those definitions that they have stewarded and concepts that they have stewarded are becoming more open to the public and to individual definition. I think the principle of informed consent is an important one in privacy legislation and continues to be important. And so I would think that that has to continue to be expanded so that individuals who choose to communicate through email and take those risks have the right to do that. Much like we have a right to privacy, we should equally have a right to sacrifice that privacy if we're trying to achieve other public goods. And as long as it's informed consent, I think we have to evolve that way.
Great, thank you. I'm going to answer one quick question on here, which is where can we access the reports and the description of the work coming from the 17 teams that CHSRF has supported on patient engagement. And I would encourage you to go to our website at www.chsrf.ca, and you will be able to find that information on our website. And increasingly, going forward in the future, we will be putting as much information about that as we can on our website. It will be undergoing some enhancements over the next several months, and you should be able to get more and better information on the work we're doing on patient engagement as well as other things from there. We are almost out of time. A brief word to any of you, any of our speakers today, on the final question, which is, how do you think this new technology and the kind of work that we're doing will impact on health human resource planning? And any thoughts about whether there would be whether this would facilitate across Canada interprovincial care as opposed to intra-provincial care? Any comments on that question?
What a great question. And in fact, my favorite emerging topic is the fact that we've got such a great healthcare system, we should be able to export it, but also the interprovincial boundaries are going to drop here very, very quickly as we start rearranging, particularly on the diagnostic side. Already we're seeing telepathology being moved from Newfoundland and Manitoba to Toronto, along with from among Ontario centers. So there's a huge opportunity. Overall, This is probably a big part of solving our HHR problems, and the ability to reconfigure and ultimately do healthcare for export means that we can tap huge markets with good, clean knowledge economy jobs and create a vibrant economy here around our healthcare expertise.
Wow, thank you.
And I guess I would add to that around really building the HHR capacity for patient and public engagement. It is an art and science. Patient experience is part of the quality agenda, and just like we're building in quality improvement skills into our teams, we need to build in the skills, the art and the science of engaging with the public and using social media tools. So we need to kind of look at that across our HHR and determine who has the skills to advance this agenda.
Okay. Thank you, Kelly. That's great. We are basically out of time. I'm sorry to say that we weren't able to get to all of the questions. We do have some people waiting in a queue on the phone. What you could please do is submit your question to oncall@chsrf.ca. That's oncall@chsrf.ca. And we've been thrilled to have so many great questions today. The terrific questions that we've been able to get to, but also many others that we haven't been able to get to, and we thank you for those. The speakers have kindly agreed to respond to follow-up questions that we missed during the course of the call today by email. So we do encourage those of you on the phone to submit those questions you have to the email address I mentioned. And the speakers have kindly agreed to get back to you over the next few days with follow-up to some of the questions that you have. We'd also greatly appreciate your participation in a very brief survey about today's CHSRF On Call. And links to the survey will be sent via email in the next 24 hours. It's really important for us if you would please respond to this. It just takes a few minutes, very, very little time. It really helps us in planning these calls, both in terms of going forward, but also in terms of making these calls as substantive and as interesting as they can be. Most importantly, I would like to thank very, very much Matthew, Will, and Kelly for 3 excellent presentations, terrific answers to the excellent questions we had, and what I think is a very stimulating call this afternoon about an issue that we are going to be talking about a lot more as we go forward in the future. So thank you very much to the 3 of you today. Thank you to all of you for coming online and for the terrific questions. This concludes our CHSRF On Call for today. I'm Stephen Samus. We look forward to engaging with you next month. And for more information about that, please sign up for our newsletter at CHSRF. Thanks very much. Goodbye.
Ladies and gentlemen, this concludes the conference call for today. Thanks for participating. You may now disconnect your lines.